Thank you, Galina, for the introduction. So let's move out from the coronary arteries and go to other vessels. And let's see if imaging of these other vessels can help us in a further risk assessment. Referring to a not so recent review, editorial published by Eugene Bramwell in 2006, in Western countries, we can see that more or less 85% of patients are at low to intermediate asymptomatic patients, of course, at low to intermediate risk to have coronary artery disease. And about 15% of patients are at high or very high risk. So this is the window in which an extra coronary screening test could be useful. The role of the stenosis has been assessed since many years. We know that atherosclerosis is a systemic disease, and so the search for a stenosis in another district that is mostly peripheral artery or carotid artery has been demonstrated to be effective in the stratification of patients. You can see here from this very old paper in '92 that patients with symptomatic peripheral artery disease or severe symptomatic peripheral artery disease have a worse prognosis compared to normal subjects. And also in this other study, in which was clearly defined the myocardial infarction as endpoint, you can see that mortality and relative risk in patients with claudication or major burden of disease in peripheral arteries, even if asymptomatic, have a worse prognosis. And the same has been demonstrated also in carotid district. This is a very recent paper published this year, not more than 1 month, in which carotid arteries, renal arteries, and peripheral arteries have been studied. And you can see here from this graph that there is a significant overlapping in patients with coronary artery disease and this multi-district involvement. And looking strictly to patients with carotid artery disease, you can see that the percentage of multivessel disease at left main coronary artery, main coronary artery increases in patients with involvement of carotid arteries. But the problem is not only the stenosis, as we know since many years. The paradigm is shifted from the stenosis from lumen assessment to the wall, as I can try to demonstrate in the next minutes. And in non-invasive imaging, non-invasive coronary, non-invasive peripheral and carotid angiography increased this possibility because of the rapid development of techniques, both for MR with whole body imaging with multi-channel coils and automatic movement of the bed of the patient, but also for CT. And there are some papers published in the last 10 years demonstrating the possibility of screening not only coronary arteries but also peripheral arteries in this way. And it's common also in our practice, in our center, to demonstrate the presence of severe peripheral artery disease, in this case in the right femoral artery, and both in the carotid artery here. And you usually complete this kind of whole body evaluation with a late enhancement study in which some percentage of unrecognized myocardial infarction can be assessed. And the same is accepted also for CT. Here you can see again a severe peripheral artery disease in diabetic patient, and also carotid involvement, and finally involvement of the left main of the descending coronary artery. So with MR and CT angiography, we can strongly confirm what is known for invasive angiography of peripheral vessels or carotid vessels, but the added value is not to look only at the lumen and quantifying the stenosis, but to look at the wall of the artery and for the characterization of the plaque, accepting the well-known concept of vulnerability, where vulnerability is a general concept not only regarding the vessel wall composition, but also the general vulnerability, indicating problems of coagulation and general systemic inflammation and so on. And this, you have already seen this slide, it has been demonstrated in coronary district as well as in other districts, where the larger amount of the acute coronary syndromes occur in patients without significant stenosis, less than 70%. So we need to look for markers of vulnerability or plaque instability. And we know that are structural and functional markers allowing this assessment. Structural, of course, means the composition of the plaque and the thinning of the fibrous cap, where functional are more linked to systemic or general blood on factors or pro-inflammatory cytokines and other factors. So, from these words that I said before, it's important that a non-invasive technique can be used to visualize not only the lumen, but mostly the plaque and the characterization of the composition of the plaque. And there are some questions arising, of course, from this. It has been partially shown in the previous presentation. How easy is to assess non-invasively the coronary vessel wall? This is still a problem. It is partly solved by CT, but not completely, because anyway, there are invasive techniques that do it better. And the second question is, are there any other vascular district that can be considered similar to the coronary district? In other words, can I look non-invasively at larger and more easy to be studied vascular district to assume a risk for coronary artery disease? The criteria for CT and MR for plaque vulnerability has been partially demonstrated in previous talk, and I summarize here the three most important signs at CT. That means the lipid-rich plaque, the positive remodeling of the vessel, and the spotty calcification within a mostly non-calcified plaque. But there is no doubt that, particularly in a not so difficult district as coronary arteries, and this is the topic I am speaking about, so for example, carotid and peripheral vessels, MRI can do it better. And there are many signs and criteria for the assessment of plaque vulnerability. Here are reported the major criteria at MRI, with the most important ones to me, and also according to literature, that are the signs of active inflammation and thin cap, the thinning of fibrous cap, but also the problem of the endothelial denudation. And I go deeply in these signs very quickly. Here you can see some specimens of carotid arteries with corresponding multi-weighted MRI, in which we can analyze very precisely the presence of the lipid core, the hemorrhage, and the fibrous cap in this case. So this is a lipid-rich plaque. Or in other case, we can easily demonstrate the presence of the fissured plaque, and mostly with time-of-flight images, where the thinning on one side of the cap and the interruption of the plaque of the cap is easily demonstrated, as well as factors such as endothelial denudation that can cause platelet aggregation and fibrin deposition, as demonstrated in this study, in which you can easily see the presence of this material with low signal intensity in both T1 and T2, and also proton density images, that is the fibrin deposition on the fissure of the plaque. Of course, the significance of stenosis still remains an important factor for plaque vulnerability, even if the other I mentioned before are more relevant. Why? Because the shear stress of a severely stenosed vessel can cause thrombosis and sudden occlusion, of course. But the problem, as I told you before, is that with coronary MRI, we have a lot of problems, mainly problems of spatial resolution, and so the assessment of a stenosis and quantification of a stenosis with coronary MRI still remain a strong, a very strong challenge. For carotid arteries, it's a little bit different, and I try to demonstrate this through another important factor that is out of only the problem of plaque vulnerability, but is enlarged to the patient and blood vulnerability. It is well known that inflammation, systemic inflammation, may contribute to destabilize the vulnerable plaque intended as lipid-rich with thin fibrous cap plaques. And it is also well known that multiple unstable coronary plaques are present in acute coronary syndrome. One is the culprit lesion, but the presence of multiple vulnerable plaques has been assessed. How? With many techniques. The most important one, of course, is the IDUS technique. And this has been recognized and published in many important journals. I want just to mention a study that we performed on this, in which we compared vessel wall imaging of carotid arteries with signs of systemic inflammation, so plaque inflammation versus systemic inflammation, through the sample of CRP, that is a validated marker of systemic inflammation. And we compared two groups of patients, two small groups of patients, but with a large number of plaques. 19 with unstable angina and carotid plaques with non-significant stenosis, with patients with stable angina and again carotid plaques without significant stenosis. No differences were present among risk factors about risk factors for these patients between the two groups. Of course, patients with inflammatory disease, systemic inflammatory disease, and recent cerebrovascular accident were excluded from the study. And we used as MRI criteria of plaque inflammation and increased T2 signal intensity more than 50% of the plaque area, meaning the edema due to acute inflammation, and the enhancement after gadolinium injection more than 2 standard deviation above the 50% of the plaque area. These are the Huyuan criteria that has been validated. For systemic inflammation, of course, we based on high sensitivity interferometric method for CRP sampling. And these are the results of this study, in which there is a very high significant difference between the stable angina patient and stable angina patient in terms of increased T2 signal intensity, meaning edema, and gadolinium enhancement, meaning neovasculature within the plaque. And moreover, patients with signs of local plaque inflammation showed, compared to patients with unstable, without enhancement and after gadolinium, so non-inflamed plaques, showed threefold levels of CRP. So we can conclude from these studies that patients with unstable angina exhibit MRI signs of possible plaque inflammation in carotid arteries more frequently than control subjects, meaning control subjects as non-healthy subjects, but patients with stable angina. Another important point is that patients with unstable angina and inflammation signs at MRI show higher CRP levels than patients with unstable angina and no inflammation signs, even if this is a minority of our patient groups. And that gadolinium enhancement within a carotid plaque is associated with higher levels of CRP. So, going to the conclusion, which kind of patients can benefit from other vascular district vessel wall imaging? If you remember the first slide I projected, the one from the editorial of Eugene Brownwell, from the same paper there is this very interesting flowchart in which patients with a high risk for after conventional score systems like the Framingham, for example, undergo intense global risk reduction through common factors intended as secondary prevention. And these patients can benefit from non-invasive imaging for vessel wall, for looking for plaque vulnerability. These are the patients that can be imaged for other vessel district, particularly for the assessment of the wall, vessel wall. And here we can furtherly stratify the patient with very high risk. That are the patients that probably can most benefit from invasive imaging for vulnerability, that is generally speaking HIVUS technique. And so this patient can be directed to newer therapies for risk factors lowering. So which are the take-home points of this short discussion? First of all, cardiovascular risk classification is still based on common score systems, clinical, whatever it is in the Western countries, in the States, or every society has its own system, but more or less all are well recognized. Furtherly, atherosclerosis is a systemic disease and should be considered as a systemic disease at all. And in plaque instability, that is the most relevant point for the cardiac events, inflammation surely plays a major role. In patients with high to very high risks, non-invasive imaging intended as an assessment of stenosis, but mostly vessel wall characterization, these tests should be recommended as a gatekeeper for invasive techniques such as HIVUS, for example. And finally, that carotid districts seem to be ideal for this kind of evaluation with the current available techniques, of course. Maybe in the future it will be easier to study the coronary plaques, but at the moment it's not the case. And for carotid district, there is no doubt that MRI can give us more and more information over CT. With this, I finished, and thank you very much for your attention.